All right, so first things first, we're going to prepare a patient for intubation. That's going to start with ramping the patient and getting them into the ear to sternal notch position. This is going to be the best position, and it's going to line up the oropharyngeal and laryngeal axes. So we have a blanket put underneath the patient's head to help ramp it and get to that position. We also have a nasal cannula at 100% oxygen at 15 liters a minute, and a BVM. We're going to breathe about one breath every 5 seconds. This is going to help achieve nitrogen washout and get our patient to as best prepared for intubation as possible. So since we have the oxygen and our positioned patient, we're ready to assess to see if they're going to be a difficult intubation or not. So this is moving into our lemon assessment. So starting with L, which is looking externally, we're going to see if our patient has any short neck, masses on their neck, obesity. These are all indications that this patient might be a difficult intubation. We're also going to move into examining the patient's 3-3-2, which is there's going to be 3 of their own fingers between their teeth, 3 fingers from their mandible to their hyoid bone, and then 2 fingers from their hyoid bone to their thyroid cartilage. This is going to indicate if their airway is more anterior or if whether or not it's going to be a difficult intubation as well. From here, we're going to move into the Patti score, which is you're going to ask your patient to open their mouth as wide as possible, and you're going to take a look. And what you're trying to achieve is, with a Patti 1, you're looking at the posterior oropharynx, the whole uvula, the pharyngeal arches, and the hard and soft palate. And that's going to be associated with a relatively easy intubation. Moving into a Patti 4, you're going to only be able to see the hard palate, so any of the structures in the posterior oropharynx will not be seen. This is associated with a difficult intubation. Moving forward from Patti, we're going to move on to obstructions. So obstructions can be anything from blood, emesis, pus, broken teeth, anything in the airway that might cause an obstruction when we get in there or if we sedate our patient. So with this, we can suction that out, keeping in mind that we might encounter obstructions below the airway that are out of sight right now, which is hematomas or tumors. And then moving forward, we're going to go into neck mobility. So any patient that is possibly a trauma patient or in a C-collar is going to pose for a difficult intubation, as well as somebody who has spinal abnormalities or a stenosed neck. This will indicate this patient might be difficult. So moving forward from our lemon assessment, we're going to prep our airway equipment, which is also known as SOAP-Me. So coming over here, we're going to make sure our suction is turned on and working appropriately. So when we suction in a typical adult patient, we're suctioning at about 80 to 100 millimeters of mercury. We're also going to make sure we have our McGill forceps out and ready to go, tucked underneath the pillow. This is going to be for in case we encounter any obstructions in the airway when we get in there and take a look. So we've been oxygenating our patient for about 2 to 3 minutes now with the nasal cannula and the BVM. And we're going to just make sure that our saturations are as best as possible. So right now we're sitting at 99% oxygen saturations and the end tidal of 34, which I'm pretty happy with. That gives me a safe period of apnea. Moving forward from that, we're going to make sure our airway equipment is out and ready to go. I'm going to assume this patient is going to be a difficult intubation, and I'm going to use the bougie. So with the bougie, there's 2 ways of using it, and the way I have it set up right now is I have the endotracheal tube wrapped around the bougie with the bougie tucked through the Murphy's eye of the endotracheal tube. This will make it so that I can use the bougie to help slide into the airway between the vocal cords and then slide the endotracheal tube off and set it appropriately. The other way of using it that I'm going to use this time around is I'll have the endotracheal tube off of the bougie, and I'm going to have it prepared on the patient's chest. And I'm going to use the bougie to go in, I'll visualize it going through the vocal cords, and then I'll have my partner slide the tube over top. So I'll make sure the bougie is out and ready by my patient's head. With this patient, we're using a size number 7 endotracheal tube, and we're going to have a size up and a size down. So this is a size 7.5 and a size 6.5, just in case we run into any problems with our intubation. That being said, we're also going to have a rescue airway out and ready to go. In this case, we're using a King LT. I'm going to just make sure the cuff inflates appropriately. There's no holes or deformities in the cuff, so we can seat it properly. So we have that ready to go. We also have our cric kit open and ready on the patient's chest, just in case this intubation turns into a surgical airway. We also have a OPA and an NPA in the patient right now while we're pre-oxygenating, just to achieve the best oxygenation that we can. We have a stylet that we won't be using in this case. We have our Thomas tube holder under the patient's neck ready to go. And we have our esophageal detector device, which we'll use shortly after placing the intubation tube. And then we have our laryngoscope and our blade. So the blade's attached. We're using a Mach 3 for this patient. And the light works and it's working appropriately. It's going to give me the best view of the cords as possible. So we'll have that all towards our patient and ready to go. And then at this point, we're going to make sure that we have our monitor on. It's facing my team so that we can all see what's going on and keep track of the vitals while we're intubating. And then we're also going to make sure that we have our end-tidal CO2, which is closest to our patient. Because with an end-tidal CO2, we're looking for a waveform, and that's the gold standard for intubation. We have a blood pressure cuff on, and an SpO2 and a heart rate reading as well. So we're going to keep an eye on those and keep those monitored. So we have all of our equipment ready. So I'm going to go over a final checklist, and I'm just going to ask my team and make sure that everything is confirmed. So we've done our lemon assessment. We've determined this patient's going to be a difficult intubation, so we're going to use a bougie. Is that right?
Yes.
Okay. We have a BVM with 2-person bagging.
Yes.
We have a nasal cannula at 15 liters a minute.
Yes.
Oxygen is flowing.
Yes.
And the patient is ramped and in sniffing position.
Yes.
Okay, we all have our PPE and gloves on.
Yes.
And I have my mask right here. We have an end-tidal reading on the monitor. We have vital signs being evaluated. Our suction has been turned on and tested.
Yes.
Yes.
We have McGill's present beside the patient's head.
Yeah.
We have our laryngoscope and appropriate blade.
Yes.
We have our 10 ml syringe attached to our tube.
Yes.
We have rescue airways and our EDD prepared as well.
Yes.
And we have our holder underneath the neck.
Yeah.
All right. So at this point, I'm just going to get my team members situated and let them know what their roles are going to be in the intubation. So Jevin, if you don't mind, I'll come in between you guys, and then when I place the tube, I'll take elm, and if you can take over elm for me, and then pass me my tube as well. And then Jill, if you're able to count down or count up to 30 for me, and then also just read me off my vitals while we're intubating. After we've placed the tube, Jev, can you use the EDD to help confirm, and then Jill, can you take a listen to the lungs and the epigastrum?
Yeah.
So, okay, so at this point, I feel pretty prepared. Jevin, as I'm placing the bougie in, can you slide the tube over
Yep.
as well? Okay. So we'll get one more breath in, and then we'll take the mask off, and let's get the OPA out, and we'll intubate.
One,
And we'll make sure our mask's on.
3, 4,
Okay.
5, 96, 6, 7, 8, 9, 96, 10, 11, 12, 13, 96, 14,
Okay, if you can slide that over
15.
top.
16, 17,
I got the bougie.
18, 19, 96,
Okay, we're at 22
20,
at the teeth.
21, 22, 23, 24, 25, 26, 27,
Okay.
absent epigastric, lung sounds left apice, right apice, left base, and right base.
Okay, perfect. So Jill, if you can take over holding onto the tube so we don't let go of it, and then we can get the
Tube holder?
tube holder on as well. So after placing the tube, we're going to run through our confirmations. So with the confirmations, I visualize the tube going through the vocal cords. I use the the esophageal detector device and it inflated. I visualize misting in the tube as well. We have clear and equal bilateral breath sounds, absent epigastric sounds, and we also have our gold standard, which is the end-tidal waveform on the monitor. And if at any point we were to come into complications or difficulty ventilating our patient, this is when we would run through our dope mnemonic. So starting with D, we're looking for any displacement or dislodgement of the tube. So if at any point we had moved our patient or brought them to the ambulance and now we're no longer able to ventilate, we're going to check to make sure the tube's still at 21 to 23 centimeters at the teeth, and just make sure it hasn't moved at all or if the cuff is still inflated. We're going to move on to obstructions now, which can be blood, any emesis that might have been in the lungs and moved up, or a mucus plug in the endotracheal tube. and this will be corrected with deep tracheal suctioning. Moving on to P of dope is a pneumothorax, and that can be caused just from overventilating. And a pneumothorax can develop into a tension pneumothorax, which we can correct with a needle decompression. And then moving on to E, that is equipment failure. So if at any point any of our equipment has become unplugged, if the cuff on the tube has broken by any chance, if there's too much moisture in the end-tidal CO2 and not getting a proper reading, then we can correct those appropriately. And if we're unable to identify any reason why we cannot ventilate this patient, we will extubate the patient and use the best BLS measures that we can to appropriately ventilate them.